Thanks for joining us on This Week in Health IT. This is a solution showcase. My name is Bill Russell, former healthcare CIO for a 16-hospital system and the creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Today, I'm joined by Mike McSherry, the CEO of Xealth, a digital health startup. And we talk a lot of different things. We talk about Xealth a little bit, but we also talk about how health systems can differentiate themselves using digital tools. I think this is going to be a key differentiator moving forward. Great conversation. I think you'll enjoy. Special thanks to our influence show sponsors, Sirius Healthcare and Health Lyrics, for choosing to invest in our mission to develop the next generation of health IT leaders. If you want to be a part of our mission, you can become a show sponsor as well. The first step is to send an email to partner@thisweekinhealthit.com. Your response to Clip Notes has been incredible, and why wouldn't it be? You helped create it. Clip Notes is an email we send out 24 hours after each episode airs, and it has a summary of what we talked about. It has bullet points of the key moments in the show, and it has 1 to 4 video clips. So you can just click on those video clips and watch different segments that our team pulls out that we think really captures the essence of the conversation. It's simple to sign up. You just go to thisweekhealth.com, click on subscribe, put your information in there, and you'll start receiving clip notes after our next episode airs. It's a great way for you to stay current. It's a great way for your team to stay current, and a great, really, foundation for you and your team to have conversations. So go ahead and get signed up, get your team signed up, and begin getting clip notes after the next episode. Just a quick note before we get to our show. We launched a new podcast, Today in Health IT. We look at one story every weekday morning, and we break it down from a health IT perspective. You can subscribe wherever you listen to podcasts at Apple, Google, Spotify, Stitcher, Overcast, you name it, we're out there. You can also go to todayinhealthit.com. And now on to today's show. All right. This morning we have Mike McSherry, the CEO of digital health startup Xealth, on the line. Good morning, Mike. Welcome to the show.
Hi, Bill. Thanks for having me. Excited.
I'm really looking forward to this conversation. We've been near each other. I mean, I was at St. Joe's. You were incubated out of Providence, but we never really got to work together. So I'm looking forward, because I've been following Xealth for a number of years. You guys are doing some pretty exciting stuff.
Yeah, no, thanks. As you said, we were incubated inside of Providence up in Seattle, and while we were still being incubated, they merged with St. Joseph's. But we were working on the Epic side of Providence, and by the time we got to working with St. Joseph's, he had already left the system. But we're still colleagues. We're still trying to advance digital health and healthcare IT, technology to the forefront of patient care.
Well, let's start there. I am going to circle back. We're going to talk about Xealth in the middle of this podcast, but let's start with digital health. It's been a wild year, a very interesting year in digital health. How has the pandemic really influenced the digital health space?
Well, I mean, exponential growth. When all patient care essentially stopped, you went from maybe 3% of patients having done some telehealth experience to reaching 80% in some kind of targeted timelines. That's since come down. I think what we're hearing across provider systems is there's going to be a new normal of 60% back to like some in-person kind of care, and 40% remaining sort of loyal or convenient towards the telehealth experience. But that's just on the face-to-face or asynchronous kind of engagement level. The other explosion in digital health was around virtual care for certain disease states. And you take a look at the diabetes management, the behavioral health, hypertension, remote patient monitoring, that increased exponentially. And I guess the high water mark of that was the Teladoc Livongo merger, where Teladoc bought Livongo for $18 billion. And that's just a sign of the times of the rise of digital health and app-based care management, online telehealth coaching specific to disease state, RPMs, i.e. like continuous glucose monitoring, or patient engagement, metrics, tracking patient adherence and engagement to that. So it's not just the telehealth, which oftentimes gets lumped into digital health and the new front door strategies, but it's the end-to-end care referral into these apps and services and in-home care treatments and the RPM associated with that.
Did the Livongo valuation surprise you at all? Is that an indication of the potential that exists in this remote patient monitoring and in really digital care plans?
It was absolutely shocking, I think, to me and the market. But I think Teladoc's playing the long game here, that there's going to be modality of care delivered virtually, and Livongo's expanded beyond just diabetes management. They do pre-diabetes, they do behavioral health. I don't know if they've bought or built an MSK solution yet, but you assume that they're going to expand into all sort of chronic care disease states. And I think Teladoc, took a bet that this is going to be a not quite a winner take all, but certainly, an oligopoly type structure, against that. And it was worth $18 billion to them. I haven't looked at the stock price now. I don't know, how much it's come down, whether it's still, worth that on their balance sheet, but they're playing to have, back to that 40% is going to be delivered, telehealth and virtual care. And then the downstream referral, if you can cost contain and keep that into your own in-house solution state, you're going to be able to provide lower cost of care. And we all know that that's the end game. How do you provide a lower cost of care at equal or better outcome levels? And that's what they're betting on achieving. And they're the first out the gate. You have to assume that Omada and WellDoc and a couple of these other platform plays have achieved, multi-billion-dollar evaluations, and creeping up into that level. But it was a shock to the industry and a real wake-up call. How the industry is responding, is measured in different increments, depending upon which sector, payer, provider, employer, pharma, et cetera, as to how aggressively they're playing in this digital health game.
That feels to me, I'm already way off script here, but that feels to me the entry point that you're going to compete with health systems appears to be to get in the way of primary care, and also to figure out a way to essentially bypass all of it and go straight to the home. And I've talked to some people about just this concept of the Airbnb for beds, for hospital beds. I mean, if we can continue to build beds with a high acuity in the home, that appears to me to be the place that the digital startups can really, I don't know, it's sort of, surprise is the wrong word. It feels like it's the wrong word, but really surprise, start to take some of that revenue, slowly take some of that revenue away from traditional providers and payers.
Yeah, at the end of the day, I think it's going to be a hybrid model. I mean, look at Optum, buying physician practices so they can actually have some face-to-face care delivery. But you're right. So much is going to this virtual first touch point, and payers have, Express Scripts Cigna just bought MD Live. So much is going to this telehealth first, and payers that control the premium, control the patient, out of pocket, can incent, like, start with my telehealth experience. And then you've got the new entrants, the Amazon Care, you've got the new front doors of what Walgreens is trying to do, what Walmart's trying to do, and they're all starting with these virtual experiences. But if you start with the virtual first, and you can kind of treat whatever that care protocol is with that patient need virtually, they're all trying to have asset-light infrastructure to refer virtually. Teladoc buying Livongo, Express Scripts building their digital health formulary, Optum, United building and buying their own formulary. They bought they bought Vivify. They're building a diabetes management solution. So in as much as they can refer patients virtually, they're going to. I mean, how many people start an e-com experience, then choose the in-store pickup option? No, you want to close loop in as much as possible on that virtual experience. If it's satisfactory and achieves the need of resolving that patient issue. And only then, if you can't solve it virtually, do you refer them to the expensive hospital system infrastructure. And keep in mind that everything we just referenced, the Amazon, the MD Live, the Teladoc, the Livongo, they're all commercially insured patients. And so if these commercially insured patients get routed away from hospital systems, then that destroys the provider finances, if they're solely reliant upon CMS and Medicaid, Medicare reimbursement structures.
Yeah. All right. So let's let's talk about the viability of some of this stuff. We've seen a lot of progress over a number of years, a lot of money coming into the space. Digital tools. Let's talk about that progress. And really, I'm going to go in three different directions here. And the first being, let's go with quality. Have we seen digital tools impact quality? Do we have those kinds of metrics that we are showing people to say, look, we can provide a better level of quality if you implement these digital tools along the way?
So in our definition of digital health, it spans from patient education to shared decision-making tools to apps that manage diabetes or hypertension or behavioral health, as well as the facility of prep and recovery. So when you talk about quality, in many cases, we're sending out pre-surgical educational material or pre-surgical digital pathways. Stop eating here, stop drinking here, make sure you bring this to the hospital system, make sure you have this at home on the recovery pathway. And so that addresses quality, even though it's a digitized patient education experience. So is that digital health? Maybe not in the quote app-based world, but it is digital engagement with the patient that's leading to better quality and outcome measurements. So that's one definition. We've got data showing behavioral health. Silver Cloud is a behavioral health app. We've launched that at 3 different systems, and we're enrolling about 2/3 of all the patients who've ever been prescribed that app actually adopt the solution. And then 75% of them are showing improved PHQ-9s. So that is definitely an outcome and quality measurement metric against that. We do an awful lot in maternity care, and in maternity, highly expectant mom, highly engaged against her care in the newborn child prep, the sort of what to expect when you're expecting on that level. And what we're trying to do is correlate how much is in light of telehealth, that all needed to have device accompaniment. So how is the blood pressure, cuff, and scale weight of the mom tracking against her healthy pregnancy, so that otherwise healthy mom checkup can be done in a telehealth experience with that added device diagnostics. So that's leading towards quality outcomes. We try to correlate that directly to low NICU events or reduced low birth weight events. But quality scores solely based on digital engagement is the only kind of attribute is probably a little difficult against all the other social determinant and other kind of considerations associated with that mom and the healthy birth of a child.
Yeah, so that's quality. When we look at experience is one of those areas that's really in the wheelhouse of a digital solution, a digital set of tools. Have the habits, have the demands from the consumer changed, do you think, over the last year to say, look, digital first? I mean, from a safety standpoint, this is what I was hearing when I was talking to people. They were happy with their online visits. They were happy with remote monitoring for chronic conditions. And the reason they were happy is because they were told that it was unsafe to go to the hospital. And so they found a solution that they felt was more safe. But after doing that for 9 months, do you think that changes a behavior? Do you think there's going to be more engagement from that perspective and conversely, a better experience all around?
Yeah, there's absolutely. And, we all talk about the consumerization of healthcare, and we can all do mobile banking transactions. We can book flights on our phones or, websites, et cetera. So much of your consumer life can be transacted digitally. But when you hit the healthcare world, there's phone calls, there's faxes, I jokingly call it the lowest common denominator. Hospital systems like, well, not if 100% of people can't do something on their phone, then let's go to the lowest common denominator and make sure everyone makes a phone call or comes in for a face-to-face visit. And that does not meet consumer expectations. They can so easily transact in their consumer life against every other element of life digitally, but in healthcare, it sort of hits this analog experience level. But that's changing, and it transacts with booking an appointment. I think almost in most scenarios now you can book appointments with digitally but maybe not that specialist referral. That has to be a phone call that transacts with that, and then all the way through to the patient experience, whether it's done telehealth or virtually, and then the resulting care protocol and treatment, and whether or not the person felt that they had a successful outcome. When you look at that whole like transaction experience, compare that with, like, say, Uber. The magic of Uber is press a button, phone shows up, you leave, and you don't have to give cash or pay a credit card, or deal with that, like, 2-minute delay climbing out the taxi while you're in a rush to go do something. So, but the ride itself is kind of hit or miss. Am I going to want to talk to the driver? Am I going to trust the driver? Is the car going to be clean? Especially in this kind of COVID pandemic, who was in it before? Is my mask safe? All that level of, like, uncertainty. Compare that with the patient experience here. The pain in parking and navigating through the walls of a hospital system and just getting there in the waiting room and lobby. Your little 15-minute window with that hospital system, with the doctor, with the nurse, that's magical. Everyone loves it and says, oh, I had a great visit with my doctor. But boy, it's such a pain on the front end to book and transact and get to that appointment. And then upon leaving, like, you're handed a brochure full of papers, or go here to get that, or make this phone call to follow up on that front, or it's an opposite end of the experience spectrum. And what healthcare needs to do is solve that magical middle and the bookends to create a seamless, consumer-friendly experience to that patient care.
Yeah, it's interesting when I talk to some people that talk to me about they were implementing wayfinding to make it easier to go through. I'm like, well, step back one step from that and figure out a way to make it so easy that they don't need wayfinding. And they sort of look at me like, what do you mean? I'm like, well, I mean, do you remember that? I don't know if you remember this, but a CVS CMIO once talked about, they were putting Epic in. He goes, why are you putting Epic in? And it was a health system executive who was asking him the question. He said, do you think you're going to be able to compete with health systems? And he said, yeah, I absolutely think we're going to be able to compete for some services with health systems. He said, well, why do you think that? He goes, parking. That was the whole answer. I thought, yeah, that's true. I mean, that was parking is one of the biggest complaints of going into a health system. The campus is big. It's hard to find where you need to go.
Yeah. And that just devolves even further to just convenience. And,
yes.
and convenience spans a whole range of activity and interactions.
So are health systems going to be able to start to really differentiate with each other, against each other potentially, and differentiate in their communities based on a set of digital tools?
Well, I don't know if the question so much is health systems differentiating against each other or against the new entrants and new competitors.
Yeah, that's probably a better question.
And there's going to continue to be consolidation in the U.S. provider industry. I think, and rightfully so. You don't want too much density in a single market, et cetera. But take a look at, the two biggest systems, not-for-profit, Providence and Ascension, both probably do 25 billion a year in revenue. What did United Optum do? 250 billion? National scale, 10x the revenue, frankly, 10x the profit probably. So they can just reinvest in these convenience, these digital platforms, these behavioral elements. And so I think that's the differentiation that hospital systems are going to have to do, is how do I remain viable, and not viable. There are always going to be entities, the acuity, the ED, infrastructure, and that element. But is a lot of the low acuity and chronic care going to get siphoned off to these more virtual solutions and payer kind of directed solutions, and with payers even kind of building a lot of clinics? They don't have to the high acuity surgery centers. They can just focus on the chronic care, which is the bulk of the cost in the country. And if they're so acutely managing steerage on that front, the unnecessary surgical procedures and the MSK before the spine surgery, kind of remediation, those types of opportunities will certainly hurt the finances of hospital systems. So if I were hospital systems, I don't know that I'd be looking at my neighbor across town as being my competitor. I'd be thinking 5-10 years down the line, how am I more effectively competing against these payers and new entrants to have skin in the game and maintain that patient relationship. And as we just discussed earlier, I think there's going to be a 60-40, 60% still going to be the in-person, care, and 40% is going to go virtual. And if you use those numbers, the hybrid model wins, but you have to have the seamless experience that bridges between telehealth is appropriate for XYZ, I'll go in face to face for this procedure, or this annual wellness visit, or whatnot. But if you can't seamlessly intermingle those two different dimensions for ease of consumer and patient convenience, you're gonna risk losing all of them.
Yeah. Well, Mike, let's talk Xealth for a little bit. My understanding, digital prescription platform for integrating digital solutions into treatment plans. Is that still where it's at, or give us an idea of what you do for payers and providers?
Yeah, so we're a platform that lets clinicians prescribe digital health tools to patients. We engage the patients typically under the hospital system's patient portal, so it's all white labeled to the hospital system and or the doctor themselves. And then because it's all digital, we track whether the patient is using device data, remote patient monitoring. So we've integrated over 40 different vendors on behalf of our hospital systems: patient ed, articles, videos, apps, maternity care, diabetes management, behavioral health, pre-op surgical pathways, post-op PT, OT rehab, MSK solutions. We've done a number of device integrations, CPAP devices, continuous glucose monitoring, RPM solutions, COVID specific, and then more generically services. We've done pre-surgical product fulfillment. We've done several different meal delivery services. We did Kroger quarantine kits for COVID positive or suspected patients. We've done Lyft rides for patients, Amazon product recommendations. So our platform's pretty broad in that whatever the clinicians think can be digitally facilitated to improve that patient care or ease of experience, we can put it into our prescribing and then engagement, workflow. What certainly kicked up post-COVID is the degree of RPM associated with that and the heightened need for that to make telehealth visits more appropriate, applicable, and even be able to bill for because of the device requirements against some of the RPM code billing.
All right, this is the part where I ask very basic questions, not because I don't know some of these answers, but just to get into the meat of it. So how a physician interacts with this is generally through the EHR interface. They will go in there, and just like they're prescribing a medication, they'll prescribe a device, a glucose monitor, those kind of things. And Xealth facilitates that prescription from that end. And then is that pretty accurate? Give me an idea of how the physician interacts with it, and then give me an idea of how the patient interacts with it.
Yeah, so on the physician side, the analog is 10 years ago, physicians used to handwrite on a piece of paper and hand a piece of paper to a patient, and they'd take that to a pharmacy. And then a company, SureScripts, came along, and the ACA sort of mandated usage of that. So now 90+% of all medications get e-prescribed via SureScripts to the pharmacy of your choice. So think of us as the SureScripts of digital health. A clinician, we're clinical decision support. We take a look at, in real-time basis, the patient's vitals, clinicals, diagnoses, insurance eligibility, age, gender, et cetera. And we use all that data to filter what digital tool is most appropriate to address that patient care. And the clinician can click a button. Doctor, nurse, MA, we can have rule configurations that require the doctor to do it, akin to prescribing a med, or it can let anyone do it. We can also automate it. So if you have enough confidence with what you want to do against a conditional match, just automate the enrollment to that patient. And we do that against pre-surgical prep, pre-appointment prep, pre-consult shared decision-making, post-discharge and enrollment in a PTOT rehab program, or product recommendations in the recovery against that surgical procedure, whatever. So 90% of the prescribed activity we do is on some automation routine versus a clinician clicking a button. In maternity care, we automate enrollment in a maternity care app to all moms over the age 18. But if under the age 18, it's a subjective decision by the clinician to click that button or not, depending upon the circumstances. So we've got that flexibility. On the patient experience side, we send emails and SMS to the patient, message from your doctor branded to the hospital system. It's that message from your doctor. We typically get 60 to 80% open rates on the material we send to patients. In some cases, even higher. No direct mail campaign from any consumer company, insurance company, and anything else will get that level of usage, because it's coming from your doctor and it's teed up against a face-to-face encounter you just had, or you're prepping from an appointment, or you just left a surgery or an appointment. So it's just kind of immediacy and timely against the patient mindset that they're coming in for some care treatment, and recommendations against that. So email, SMS, we can force the patient to log into their patient portal, web, mobile, or we can bypass that with the more simple date of birth configuration authentication for the patient. And then they're click to download, click to register, click to buy, click to watch, click to answer. It's whatever that third-party solution is providing depends upon the level of patient experience in engaging with that app, content, article, video, etc. But again, since everything's digital, we API integrate to all these third parties, and then back in the EHR, we monitor the patient usage of that app or device or program and bring that data in real time for clinicians to make care assessments. And we've got a number of alerting mechanisms to trigger alert notifications when patient is non-compliant, or device or app data is falling outside of threshold ranges, or it's a necessary step in the completion of the next step in a routine, i.e. a consent form or shared decision making or something else. So we just close loop that whole experience level. And I'd say over time, we hope to be the benchmarking of digital health effectiveness in the US. We're working with the largest IDNs in the country, and we've integrated, again, 40 plus different vendor solutions, and we're seeing the efficacy of engagement levels and ultimately trying to marry it up to outcome levels, so that we think we'll have the segmentation of knowing what apps and tools produce the best results against patient segmentation. And so much of this is focused on chronic care management, and that's behavioral change. It's hard to imagine one size fits all at addressing patient care, and that something that works for a 70-year-old Hispanic, grandmother might not work for that 17-year-old kid going through teen angst and measuring some level of, care treatment. There's going to be different tones, different voices, different segmentation of telehealth specialists supporting, that certain disease state. And we think we're going to be in the position of being the quantitative aggregator of all that data.
So you're really we overuse this word, but in the true sense of the word, you're a platform for enabling digital transformation. Is too much of a buzzword. I would say the delivery of digital health through existing IDNs that have very traditional models, but once the platform's in play, they can then look at their workflows. They can then look at their care plans and whatnot, and they can integrate the digital components. You guys just sit there and help them to just integrate those things and really, help them to make that leap into a digital future for healthcare. Is that closer to what you guys are doing?
Yeah, and back to that SureScripts analogy, they have 90% market share of EHR. They're ubiquitous at e-prescribing meds. We want to be ubiquitous at e-prescribing digital tools and digital apps and devices. And I think that manifested itself, one of the positive to our business, Cerner invested in us a few months ago and are reselling us to their provider base. So they're essentially chose us as their default platform for being digitally enabling all of their provider systems. And we're already working with, 13 of the largest Epic systems: Providence, UPMC, Mass Gen Brigham, Advocate Aurora, Duke, Atrium, Baylor Scott White, Allina, Memorial Care, Atrium, et cetera. So we think we're working our way towards that ubiquity level, and we're building the two-sided marketplace. We add all these large provider systems. They tell all these vendors to integrate to our platform, and then we've built this two-sided marketplace of provider distribution and the cross-platform enablement. A vendor does a single integration to us, and then we can span them to both Cerner and Epic deployments. And we've got other EHRs on the roadmap in the future as well.
So talk about the buying decision, specifically for healthcare providers at this point. What's the progression that they usually follow to get to a Xealth implementation?
Well, selling to hospital systems, it depends on who's got the budget and who's got the clout. But as we've just been discussing at a platform level, we need a clinical champion. We need doctors, nurses, MAs saying, I need to digitally engage my pregnant patients, my surgical patients, my diabetic patients, my behavioral health needs. You need the clinical champion saying, I want to digitally engage my patients in X. You need the CIO that our aggregation strategy, our IT scalability, the IT security framework, that is going to provide an ROI cost savings versus them trying to do it themselves. And then increasingly at hospital systems, you've got a chief digital officer, patient experience, population health. They care about adherence and engagement and RPM, so that if they're running the capitation risk, they can effectively monitor the patients. So we need to convince that swath of executives at a provider system that our platform has benefits. And our budget almost always comes from the CIO, but in some cases the CIO is also the chief digital officer and the innovation lead in charter with digital transformation. And in other cases, there's a chief medical officer who's on the front of the transformation experience. In other cases, it's the chief digital officer and innovation. That oftentimes, coincides with investment, kind of leaning out into the market. And 6 of our large hospital systems have also chosen to invest in Xealth: Providence, UPMC, Cleveland Clinic, Atrium, et cetera.
Wow. So I'm curious though. I mean, because you guys have been around now for a little bit. I mean, in startup years, you're well past your teen years. Give me an idea. Does the sales process change? I mean, early on you talked about incubation, and that was probably very focused on a set of use cases that you were working with Providence. And then you go out to market, and there's probably a different kind of sales phase, and then you start to scale. I would assume that there's sales looks a little different as you progress, but I could be wrong. What does sales look like?
Well, there's pre-COVID and post-COVID, and
Sure.
and where systems are leaning into a more expansive future, like to better compete, and they assume they're going to be the consolidators of other systems in the market. And then you've got systems that are in retreat against their financial impact, and how are they going to outcompete the new entrants. So there's a classic innovator's dilemma. Can hospital systems afford to invest in a digital health future, or can they afford not to? And some are making that decision, and we'll see how that plays out in the competitive dynamics in the coming years. It's been a huge boon for our business in that we literally 100x the volume of prescribed activity during COVID, and the level of the digital engagement. And part of that was just it was the only way to engage patients. So several systems were reaching 100% of the patient populations against education on how to do telehealth prep, education around COVID safety and protocols, or 100% of pre-surgical patients got reached with COVID safety protocols and awareness, and pre-surgical product kit fulfillment, et cetera, to incent all the elective surgeries back to the, again, safety protocols. So as we go forward in the future, I don't know that hospital systems can ignore digital any longer, but you are finding that, and this is probably my big lament in the market here, digital, we talked about Livongo and $18 billion valuation, and the MSK solutions and the behavioral health solutions, and that massive rise against all that. Most of those solutions in chronic care have been targeted at payer and employer. And that valuation escalation has been focused on those distribution channels, not provider distribution channels. And providers need to step up their game in both capitation exposure and risk, as well as digital enablement of convenience and options. Otherwise, they're going to risk losing that new front door strategy. But it's been a massive boon in success for Xealth in how we're interacting with existing customers and the large IDNs that are coming to bear. Our smallest customer, I think, does $2.5 billion in revenue, so we're mostly targeted at the large tier IDNs. And then there's going to be a question of how are the mid-sized systems going to adopt a digital engagement future, and we've got some strategies, especially in line with Cerner reselling Xealth, that are going to address that market, I'd say.
Interesting. Well, I've got really two questions to close. One is just another way of trying to have this discussion of the future, and then the other sort of catch-all. But let's just start with the future, which you just brought up. Let's try to paint a picture of really what the consumer experience will look like in 2025 in healthcare, given what we know about the impact of the pandemic, the investment dollars rolling into digital health startups, the role of big tech, the pace of technology change in healthcare. What might the consumer experience look like in 2025?
There's certainly going to be more proactive care delivered, regardless. The payers own the insurance, they own the risk mitigation, which is proactively engaging with patients before they start, reaching a level where they have to go to ED visits or I don't know, injured things that could have been dealt with on a PTOT, results in surgery because of lack of, intervention, et cetera. And I think with the rise of RPM, be it, your Fitbits, your Apple Watches, your in-home sensors, along with the rise of RPM kits that manage CHF or, recovery or more high acuity levels. And all of the monitoring against that is going to lead to signals that provide more proactive intervention. And the payers have been capitated. The insurance, most employers are capitated against their members, so they want to pay for all this. Hospital systems, because they lost such large chunks of procedural revenue this year, are now trying to aggressively move into the capitation risk management. And so they themselves are going to have to get into this more proactive. It's going to take longer for them to adjust their business model, I'd say. But I think that is an absolute, and some people might see that as an intrusion of their privacy and over my dead body, nothing's tracking me, et cetera. But I think there's going to be financial and business models and incentives that for the majority of Americans, they're going to say, yep, you can monitor, you can reach out to me, you can try to intervene with my care because it's cost effective and worthwhile to me against these high deductible plans or kind of other out-of-pocket expense, considerations. So I think that's probably where things are going. And don't discount Amazon's rise. I think even just this week they announced, or there's rumors that they're now licensed to operate their Amazon Cares, their virtual primary care and their nurse care delivery in home in all 50 states. And I'm fairly convinced that Amazon's going to eventually get in the insurance game and provide all those economic incentives and proactive measurements and device accompaniments. And they're going to have a financial business model that most people, like we've done with most of our consumer lives, I'm willing to give up a degree of my privacy, be it Facebook or Google or whatever other big tech, kind of mechanism we use for free, because of the convenience and cost savings that benefits me. And I think Amazon's going to crack that nut pretty wide scale here over the coming years. What's your take?
That's interesting. I wrote an article a little over 4 years ago that said the next move for Amazon is to essentially what they built out, which is Amazon Care for employers, and then get into the insurance game. So I agree with you 1,000% on that. The announcement I read last week is that they have licenses in 19 additional states, and they are going to expand. I think they are a significant player. And, when people ask me, what does it really look like for Amazon to be in care? And I said, well, think about it from a vaccine distribution standpoint. If they'd given 100% of the vaccine to Amazon, how efficient do you think that would have been? I mean, my guess is they would have had people come to your door and vaccinate your entire family, and they would have just knocked it off by zip code. And they have a ton of information. It would have been a completely different experience because they have a ton of information. They have the logistics capability. They could have handled the the deep freeze for Pfizer, the moderate freeze for Moderna, and the distribution of J&J. And it just would have been very different. And I think between now and 2025, that's going to be one of the big impacts. I think CVS and Optum are going to be another impact, that you're going to see primary care start to get pulled away from providers, in which case the activities of the consumer starts to get, directed by someone else with a different set of interests. And essentially, it's funny because I say CVS and Optum, and people are like, oh, they're two totally different companies. Well, they're not. They're both, two of the largest payers in the country who have significant presence in terms of primary care and directing care. And that's where they want to get to, a digital care platform and whatnot. But the show is about you. I mean, if people.
I mean, to go one step further on that, I'm in Seattle, Providence is headquartered in Seattle. And in this market, Optum bought several large clinics, so they're vertically stocked up. You've got Kaiser here, and now you have Amazon telling all 100,000 of their employees and dependents in this region to start with their primary care experience. So any gain of any of those three new entrants towards market share or utilization or verticalization becomes a net loss for Providence and to the Blues here. So they're going to have to become bedfellows to more effectively compete against the verticalization of those services. So I think you're going to start to see a number of like different partnerships and entities and pay-vider kind of collaborations, because it's all going to be about scale. And these individual hospital systems with their geographic monopolies or strong positions that's great for surgery and the 100-mile radius of high acuity care treatment, but things that can be done in lower cost settings or virtually, they're going to have a hard time stacking up a digital platform that meets patient expectations against more convenience options. And at the end of the day, convenience always wins.
Yeah, the other thing I'm looking forward to, Mike, and I think it's right around the corner, is insurance products that feel like they give me more choice, right? So I will sign up for a digital first insurance product if somebody comes out with it and offers it to me, right? So if they say,
haven't some of the payers come out with these like virtual first insurance plans? And
yeah, and we have that now. We have a virtual. All your primary care begins with a virtual visit, and then they send you off. But that's really as far as it goes right now. But I think where it goes next is, okay, even larger than that, it elevates above the geography, and they say, look, here's what we're going to do, and it's what Walmart and others have done, right? So I'm a small business owner, and they come to me and say, look, digital first, remote patient monitoring for your patients. We're going to do an employer type program for fitness and wellness and behavioral health. And oh, by the way, if you have a cancer diagnosis or something to that effect, you can get care at Mayo or at I don't know, fill in the blank. There's
right, yeah,
UCLA or others, and essentially what they do is they stitch together, the programs that are the best in the country that I'm able to offer to my employees, that essentially, because I'm saving money here, I can make it up with maybe a higher level of service across the board in other areas. I'm hopeful they get very creative with these new tools that they have available to them.
I mean, take a look at, you've probably seen Hims and Hers, and it's a 3-year-old company. I think they did 2.5 million telehealth visits, which is last year, which is more than most large hospital systems. And they did a SPAC IPO. They were valued at 1.5 billion or whatever. But they want to be the new front door for millennials. And I think they bought a company that does in-home diagnostics and blood draws and things like that, where they'll send people. So they want to be this closed loop, entirely virtual, entirely like patient oriented, experience and convenience option on that front. And that's what millennials are adopting. That's where they're all shifting their needs to. They don't have these, long-term standing, I must see my doctor face to face because that's what I've done for the last 50 years. And so new modalities are cropping up, and certainly the convenience option is going to win out on large swaths of consumer/patient expectations here in the future.
Yeah. Well, all right. Last question. And I promise this is the last question. And I've started to close my interviews with this catch-all, and it's produced some really great results and interesting conversations. And is there a topic we haven't touched on that you think would be interesting for the community to hear about?
Well, so, I've talked a lot about the payer, dynamic of reimbursing against this chronic care management, and that's all commercially insured reimbursement. But if you're on CMS, Medicaid, Medicare, digital tools have not been reimbursed yet. And so arguably they have the most difficult time getting to that face-to-face doctor appointment. Is that taking time off from work? Is that, taking the bus to get there? Is that the expense of getting there, or parking, or whatnot through all that? And why is it that commercially insured patients have all these great digital convenience options on managing patient care when Medicaid, and Medicare patients still have to go to that, face-to-face visit? And like, oh, I'm sorry, you're on Medicaid? Book an appointment with my therapist. Yeah, we're kind of booked up. That'll be 3 months from now that you'll get some FaceTime with them. Good luck to you in the meantime. That's not, there's a health inequality that's kind of reached a level here that's been exposed that I think needs to get addressed. And CMS needs to look long and hard at the efficacy and engagement and results of these digital solutions. They're proving their worth in the commercial market share and employer kind of world. I think CMS needs to look at a reimbursement structure for those in the most acute need, out in the Medicaid, Medicare world.
Well, during this emergency time, though, aren't we reimbursing some of those things?
Telehealth, but I don't, we haven't seen that, the Livongos of the world, the behavioral health apps of the world, the Omadas of the world are being covered at Medicaid, Medicare reimbursement levels.
Yeah, that would be an interesting. It's interesting, as you were talking, why do we focus on consumers or commercial and whatnot? And I just sort of made the motion of it's just money. It's just,
Yep. The economic, incentives here, geared towards the commercially insured because of the reimbursement rates attained from there. You're seeing huge drives for that to, sort of put caps on that level, against what Medicare, Medicaid, kind of pricing, billables are, et cetera. But we'll see how all that plays.
But is the answer more reimbursement, more government money, or is the answer to reduce the costs on the, and this is a different question, but reduce the costs on the provider side to actually, figure out a way to make money on Medicare reimbursement rates and Medicaid rates? Because traditionally they haven't.
I mean, if you force caps on the provider systems, bundles, some increased cap, to what existing, Medicare, Medicaid rates are. And if you required hospital systems to cost contain against that commercial market share and bring all prices down in line, then they're going to be forced to more digital automation. Every other industry has used digital enablement, process automation, software infrastructure to reduce costs. The hospital system hasn't. They continue to add more bodies, more resources, more face-to-face exposure, which in itself is good for employment numbers, bad for the total economy and the cost of healthcare, and it gets distributed unequally out to the patient population trying to manage their care against the costs.
Yep, absolutely. Hey, Mike, thanks for your time. This was a great conversation, and I look forward to staying in touch with you.
No, thanks, Bill. I appreciate having me on, and always great chatting with you.
What a great discussion. If you know of someone that might benefit from our channel, from these kinds of discussions, please forward them a note. Perhaps your team, your staff. I know if I were a CIO today, I would have every one of my team members listening to this show. It's conference level value every week. They can subscribe on our website, thisweekhealth.com, or they can go wherever you listen to podcasts, Apple, Google, Overcast, which is what I use, Spotify, Stitcher, you name it, we're out there. They can find us. Go ahead, subscribe today, send a note to someone, and have them subscribe as well. We want to thank our channel sponsors who are investing in our mission to develop the next generation of health IT leaders. Those are VMware, Hillrom, Starbridge Advisors, Aruba, and McAfee. Thanks for listening. That's all for now.